Good evening. I thank the organizers for providing the opportunity to share the experience of treating triple negative breast cancer from Tata Memorial Hospital, Mumbai. Triple negative breast cancer is a relatively rarer subtype of breast cancer, accounting for 12 to 17% of the incidence. However, in low and middle income country, it accounts for a third of the patients. These patients are younger at presentation, they have aggressive tumor biology, and are associated with early visceral metastasis and have poor overall outcome. There is paucity of data from low and middle income countries, and we faced unique challenges in managing these patients in our resource constrained setting. This study was aimed to report the demographic practice patterns and survival outcome of TNBC patients in this setting. We included treatment naive histologically confirmed triple negative breast cancer patients who were registered at Tata Memorial Hospital, Mumbai between January 2013 to December 2019. All patients were non-metastatics and were evaluated by multidisciplinary tumor board. Data was captured prospectively in our electronic medical records, and the follow-up was updated telephonically at the time of final analysis. We identified 1297 patients during this time period. The median age of the patient was 38 years. Majority of them, that is 60%, were diagnosed with breast cancer at the age of less than 40 years, while pregnancy-associated breast cancer was seen in 1.2% of the patient, and family history was present in 14% of them. Genetic evaluation was done in 158 patients, and germline BRCA mutation was identified in 41 patients. There were more than 50% of the patients having locally advanced breast cancer with the stage 3 or T3N0. Majority of them had stage 2 and stage 3 tumor, while few of them had stage 1 tumor. Staging information was missing in around 5% of the patient. Around 98% of the patient had invasive breast cancer and OS histology. Similarly, around 98% had grade 3 tumor. Coming to the treatment characteristics, around 97% of the patient received chemotherapy. A third of them received neoadjuvant chemotherapy alone. Another third received adjuvant chemotherapy alone, while remaining third received neoadjuvant chemotherapy followed by surgery, then adjuvant chemotherapy. Majority of the patients received anthracycline as well as taxane-based chemotherapy, which was received by 93 and 79% of the patients respectively. Few patients received platinum-based chemotherapy, which was received by 179 patients. There were modest grade 3 and 4 toxicities. Common were neutropenia and febrile neutropenia, while death due to the chemotherapy-related toxicity was seen in 2 patients. 95% of the patient underwent surgery, around 60% underwent surgery after neoadjuvant chemotherapy, and 60% of the patient underwent breast conservation surgery. We observed pathological complete response rate of 40% in patients who underwent surgery after neoadjuvant chemotherapy. Around 80% of the patients received radiotherapy. Coming to the survival outcome, at the median follow-up 3.2 year, median disease-free survival was not reached, while 3 and 5 year disease-free survival was 77 and 72.6% respectively. As can be seen from the lower graph, the 5-year DFS in the patient who achieved pathological CR after NSAT was significantly better as compared to those patients who could not achieve pathological CR, which was 85.6% versus 56.4%. Similarly, median overall survival was not reached. 3-year and 5-year overall survival was 88% and 84.4% respectively. We also observed better overall survival in those patients who achieved pathological CR versus those who could not achieve pathological CR, which was 92% versus 75.6%. Stage-wise survival also was worse for stage 3 patient as compared to stage 1 and stage 2 patient, as was also observed in overall survival, as it decreased from stage 1 to stage 3. 259 patients relapsed during the follow-up. Distant relapse was observed in 204 patients, and common site of distant metastasis was lung, liver, bone, and brain. Around 1/4 of the patient had brain metastasis during the follow-up. Among these patients, 196 received palliative chemotherapy, and more than half had tumor progression. Few of these patients could receive second and third line of the treatment. Only three patients developed second primary cancer, which was ovarian cancer, all positive NSCLC, and esophageal cancer. In the multivariate analysis of prognostic factors, we identified older aged, low serum albumin at the presentation, requirement of neoadjuvant chemotherapy, presence of lymphovascular invasion, and perinodal extension as the adverse prognostic factors which was associated with poorer disease-free survival and overall survival. Key observation of our study was that our patients are young at the diagnosis, they present at locally advanced stage. We observed a higher BCS rate and higher pathological CR rate after NSAT. As consistent with the literature, higher pathological CR rate was associated with the better survival, and also majority of relapses was observed in first 3 years of follow-up. After that, we could see there was a flattening of survival curve. We also observed modest grade 3 and higher chemotherapy-related toxicities. However, there was some limitations. It was single center non-randomized data with its inherent biases. There was a short duration of follow-up. So to conclude, awareness and screening is the need of our, and we need to have global and national collaboration so that we could improve the outcome of these patients by identifying them at early stage and to develop better treatment strategies. I would like to express my sincere gratitude to entire breast TMG of Tata Memorial Center, Mumbai, all the teachers for providing their guidance, all the residents who worked on the data for compiling, statistical team, and the patient and family for their trust and support on us. Thank you.